So today we're going to talk about perioperative evaluation for cardiac patients. My name is Chris, this is Brian.
Hello.
So prior to any kind of surgery, patients need to be optimized for surgery just to make sure that when they're on the table, nothing bad happens to them. For example, if you had a patient who,
Undergoing appendectomy.
Right, like a patient who's undergoing appendectomy, if they had any kind of pre-existing conditions like they had previous stroke or they had hypertension or maybe they had a previous MI, you want to make sure that prior to them going under the knife that their heart can handle it. And so when thinking about evaluating a patient, you really need to ask yourself 4 questions. The first question being, is the surgery emergent? Because as you can imagine, if the surgery is emergent, then no matter what, patient's going to have to go into surgery anyway. In that case, the guidelines to follow are just cardiac perioperative surveillance and post-op risk stratification according to hospital policy. So that's this guy. And then, so if it's an emergency, go ahead and clinical risk stratification, proceed to surgery. However, if it's not an emergency, you now have time to start thinking about risk factors that this patient may or may not have. Specifically, you want to ask a patient, or you want to check in their chart. Do they have any kind of unstable coronary syndromes, unstable severe angina or recurrent MIs? Do they have decompensated heart failure? Are there significant arrhythmias? And by significant arrhythmias, I mean second-degree AV block, type 2, third-degree AV block, any kind of AFib, A-flutter, symptomatic bradycardia, or recent VTAC. You need to ask if they have any kind of severe valvular disease, or any kind of severe aortic stenosis, or any kind of symptomatic mitral valve stenosis. If yes, you're going to evaluate, and then you're just going to treat accordingly. You can proceed with the surgery as long as it's safe. Thirdly, you need to ask yourself, is this a high risk or a low risk surgery? Low risk surgeries are anything that are minimally invasive. We're looking at things like endoscopic procedures where there's really no major incision. Anything superficial like skin procedures, if you need to remove a mole or a rash, or if it's an ambulatory procedure which requires no overnight hospitalization. The high-risk surgeries are considered anything heart or vascular related. If you have to mess around with the aorta, if you have to do any kind of open sternotomy, or anything where there are major shifts in fluid, then you need to reassess and figure out other things. Everything else that's not high risk or low risk is considered intermediate risk. You're looking at open cholecystectomies or any kind of orthopedic procedures. If it's a low risk surgery, then no further testing is required, and you can just go ahead and proceed to surgery. Otherwise, if it's an elevated risk or intermediate or high risk, then you need to start worrying about functional capacity. Functional capacity is measured in terms of METs. So these METs, and to kind of talk about what they are, an MET is a physiologic measure of functional capacity which helps to objectively describe energy expenditure as a result of certain activities. We generally try to optimize a patient for 4 METs. To give you kind of an example of what that is, 1 MET, you're able to take care of yourself, you're able to walk indoors around the house, able to walk 2 blocks on level ground at 2 to 3 miles an hour. 4 METs, which is what they're kind of going for, you're able to climb a flight of stairs, do heavy housework, participate in moderate sporting activities like golf, bowling, or throwing a baseball. Just for a frame of reference, 10 METs or greater is considered like strenuous sports, and being able to do that. If the functional capacity, as determined by the questions that you ask the patient, is greater than 4 METs, then no further testing. So if you have moderate to good or excellent METs, no further testing is required, and then you can go ahead and proceed to surgery directly. However, if the question asked kind of says, oh no, they don't really have the functional capacity to do it, or it's really unknown, then What's generally done is different kind of, or you need to ask the question about what kind of clinical risk factors a patient would have. The clinical risk factors that are most commonly assessed for are heart failure. And so next you're going to assess for clinical risk factors. If there aren't any risk factors, so the patient is generally pretty healthy, then the patient can proceed with surgery. If there are 1 to 2 clinical factors, or even if there are 3 factors with an intermediate risk surgery, then it's suggested that the patient undergo the procedure with HR management, or they can undergo any kind of stress testing. Pharmacologic is generally the most typical in this situation. To assess if they're ready to undergo testing. If there are 3 or more clinical factors and it's a high-risk procedure, then it's suggested that the patient undergo stress testing, so they get the adenosine testing, as well as intervention. So if they need a PCI, if they need a stent placed, then you would go ahead and do that first prior to the elective surgery. And so to go over a case, we have a 45-year-old male with history of diabetes mellitus, hypertension, hypercholesterolemia, as well as history of a cerebrovascular accident who needs lung resection surgery. He's generally asymptomatic, doesn't leave the house, but can do most normal activities. His wife does most of the housework. He at most can walk 1 block. He is currently on aspirin, lisinopril, Zocor, and metformin. If we use the guidelines that are in place, we realize that the surgery that he's doing is non-emergent. He has no active cardiac conditions. The procedure itself is intermediate risk, but we're unable to really kind of assess his functional status, although we can make the generalization that it is kind of poor on the basis that he can only walk about a block and that his wife does most of the household activities. He has 3 clinical risk factors: the diabetes, I think the CVA, and the hypercholesterolemia. And so the plan for this gentleman would be to initiate non-invasive testing. We would do the regedenosone nuclear stress test. And when we did it, it showed borderline mid multivessel ischemia, SSS, equals 7, no focal abnormalities, with an ejection fraction of 50%. In the end, what we ended up doing was heart rate control for him and just to proceed with the planned surgery. With the recommendation that the patient is optimized for surgery. It's important to note that you never clear a patient for surgery, just because you can't entirely be sure that this patient wouldn't have any kind of complications while on the table. And so the best way to say it would be that he's optimized for surgery, he understands the risks, but that all procedures carry an inherent